Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can be profitable and successful for years to come. As many of you know, the NSCHBC is a proactive organization with over 300 members, including legacy members that share their wealth of knowledge and expertise with each other, with you, whether it be in the legal field, the accounting field, the RCM field, the business management field, value-based care, AI, and more. We have every kind of consultant that focuses on the healthcare industry that you could want. Today, I'd like to welcome the Edge Podcast, NSCHBC member Colin Callahan, healthcare attorney and partner with Flannery Georgalis in Pittsburgh, PA. Colin is a former federal prosecutor from the Western District of Pennsylvania, where he uniquely served in both the civil and criminal divisions. He focuses on his practice on defending individuals and organizations in a wide variety of sensitive matters, including representing clients in complex criminal, civil, and regulatory matters involving allegations of healthcare fraud, False Claims Act violation, public corruption, and government contracting fraud, and even securities fraud. Colin also has an extensive experience in matters affecting licensed medical professionals. And so we definitely have our expert here today, and I'm excited to have Colin with us. Colin, welcome to the podcast.
Thanks so much, Terry. Really looking forward to chatting with you.
Isn't it fun whenever you have something you're doing and you have an info or an intro and you're like, okay, just stop. I always feel that way. Just stop.
100%.
So our topic today for our listeners, and actually I love this topic because I know as healthcare professionals and attorneys, and I'm in the revenue cycle management space and compliance space, we all have some frustration sometimes as, we are trying to communicate with our providers, our physicians, and our healthcare clinical professionals, and trying to really get them to understand and encourage them to adopt best practices without always defaulting to legal statutes or published, regulatory guidance, and just really focus on clinical quality, risk management, efficiency, peer benchmarking. And I'm sure as a healthcare attorney, you probably deal with this as well. So just to start off the conversation, how do you kind of frame compliance as risk management and patient safety instead of always saying, well, guess what's going to happen to you with the anti-kickback statute, or if you're negligent, or how do you do that?
Yeah, it is such a great topic. And so I'm really glad that you sort of picked it for us to chat about a little bit. Especially because I have a background that really, to a significant extent, has dealt with like enforcement actions, right? Either on the criminal side of the house or from a civil enforcement perspective. A lot of times when my firm or I specifically are coming in, there are some black letter law sort of issues that we want to address when we're doing like a compliance review, when we're working with organizations or individuals. And so, that's sort of like always going to be a component of what we're looking at. But, when I'm trying to explain sort of what the path forward looks like for an organization, the conversation can never stop just with sort of correcting, if there are any, sort of those like black letter law deficiencies or the like. And, as I talk about that, I often will kind of draw upon my own background from when I was a prosecutor for years and, try and explain to folks, you are really helping yourself in a number of different ways by focusing on what best practices are, by, creating sort of a record of all the ways that you're endeavoring to maximize efficacy and patient safety and the like, because amongst other things, I think it's good for business, but as much as anything, those are all things that regulators do actually care about. Those are all things that prosecutors at the state or the federal level care about, whether they're doing civil enforcement or criminal enforcement. And so, I try and walk people sort of through, in a lot of ways, the mindset of the folks that are out there that may someday be looking at what they have or haven't done historically, and sort of articulating, sometimes with some more stories, so like ways in which adopting best practices, listening to things you might be talking about as well, Terry, right, or other consultants or the like, the ways in which that really is going to be in their best interest, if God forbid, the light of the government is shining on them someday.
Right. So basically, in a kind of and I'm not an attorney, so I appreciate
Mhm.
having you here.
Sure.
Emphasize asset protection. So basically, we're going to protect you from, lawsuits and personal assets we want to protect. But also, here's just a funny story. It actually just
Mm.
yesterday, and I'm just like, you've got to be kidding me. So in the revenue cycle space, coding space, or whatever, I have a provider who does valve replacements, and you have to have two physicians providing this service, or otherwise you can't do it. So typically it's a cardiothoracic surgeon or a cardiac surgeon and then a cardiologist. And their practice happened to just have one provider doing it, but there's a modifier that's a co-surgery modifier, 62, and they were applying it to all the claims so they could get paid. And as I'm face planting, I'm like, but you didn't have two surgeons in there or two physicians? And they're like, well, no, but if you read the statute, if you read the published guidance, it says you have to put that on to get paid. I'm like, okay, wait. It says you put it on to get paid if you have two providers in there, and you can't pretend that you don't have two providers, or that you do just to get paid. You're reading it wrong. They're like, no, you're reading it wrong. It says we put the 62 for reimbursement, otherwise it'll be kicked out. And I'm like, that's correct. But if you didn't have two providers, then you can't put it on. You didn't meet the definition of the compliance criteria to be able to do the procedure. And we went round and round about this for 30 minutes. And then there was a question that came up and I said, actually, you've been overpaid. So we're going to have to self-report and start that process. And he's like, no. He goes, we were underpaid because we only, I can't even say it out loud. We only had one provider, and we only got paid the co-provider, the co-surgeon rate at 62%. And I'm just like, do you hear what you're saying here? So it's interesting sometimes because, and again, I'm just amused because the conversation was like banging my head against the wall, trying to explain that, well, first of all, you have to meet the criteria to even do it. Let's not even talk about coding, billing, whatever. Did you have two physicians? And I showed them where it says it's mandated in three different places. And they're like, no. I said, okay, then stop the presses. You can't even walk into the procedure room. And they just weren't grasping that. So one of the things I wanted to ask you is, do you have on your end, as a healthcare attorney and a legal mind, do you ever have where you have a provider who obviously is in trouble and you're having to defend, or maybe you're on the other side when you were a prosecutor, and they bring you how they came to their decision with some published guidance or Federal Register things or whatever they interpreted, and you're looking at them like, that's not what it says? Do you ever have that?
All the time, right?
Okay, so it's not just me.
No, definitively not. And I think those circumstances, they exist on a spectrum, right? And so like there's definitely some where I encounter where it's similar to like what you were just describing, right? Where you just sort of like you scratch your head as you're looking at what the thinking was, right, on behalf of the provider. And I've got a pretty good BS meter myself after doing this for as long as I have. But like where I'll think like, man, they are telling me something that doesn't make a lick of sense, but like
Exactly.
but they genuinely believe it, right?
They
I can
do,
tell
right.
like it's not like an after the fact rationalization, right? It's not part of some like scheme that they were cooking up. Like they've just really in good faith adopted a very difficult to understand sort of view of something.
Right. I mean, I get
And
it on telehealth where somebody
right,
has said, well, I put the 95 modifier, or I put the patient was at home. And I said, yes, but this clearly shows the patient wasn't at home. They were actually out of country. So you can't put that place of service there. They said, well, that's the only way I can get paid. That always seems to be the follow-up answer. just
Right,
like,
right.
I understand how to get paid, but you have to be truthful. So
Yeah,
it's
yeah.
interesting when you get the feedback that, well, I read the statute and it shows me how to get paid. It's always about money, isn't it? But we're also talking about being compliant within what the rules say you have to do first. Then let's talk about what you got paid.
Well, that's of course right, and it's interesting, right? Because on my sort of like side of these types of cases, both when I was in government and now sort of when I'm not, I definitely do like prophylactic compliance reviews and provide advice on how to improve things where there isn't like a precipitating event. But there are also a lot of times where me and my team are coming in because there is some kind of a regulatory investigation that's going on. And so sometimes you're tweaking and improving compliance efforts globally because there's one specific thing that's really being looked at already. And I think this sort of speaks to like the dynamic you're talking about. What I then can do from a defense standpoint changes if, as I'm looking at it, what has happened historically, if there's like contemporaneous sort of proof that people were trying their best to do the right thing, even if they get it wrong, right? Because maybe they didn't talk to me, they didn't, talk to somebody like you or somebody else, that would have been knowledgeable on a particular area. But you can see in email communications, let's say, or other documents that are out there, that there are like demonstrable efforts to take compliance seriously. Maybe instances, even if it's not the thing that the government or regulator is looking at, where they've foregone like money that maybe they could have been entitled to because they were trying to apply a principle in an even-handed way. And so they not only didn't overbill, but like arguably they took a conservative position and like actually underbilled. All of that is sort of like from a narrative standpoint, from a story standpoint, super helpful, right? And so it's sort of like a tangible benefit to trying to think about things, not just in like a black and white, like, is this clearly against the black letter of the law, but instead thinking about like what best practices are, what's best for patients, what's sort of an appropriate way of handling issues.
Yeah, and I think that, there's a good kind of reference to what we're talking about here is that the Office of Inspector General has something called the General Compliance Program Guidance. Okay,
Yep.
so GCPG, which I know you know,
Yep.
and it's what they call voluntary framework. So they said you have to have a compliance plan if if you bill the federal government with Medicare,
Yep.
Medicaid, whatever. But it doesn't have a lot of mandates to it. It says this is the framework that we recommend. And it used to have 6 elements, and now it has 7 up to 9. But I noticed that the extra element actually reflects, luckily, the modern healthcare risks, but it also really focuses on patient safety and data analytics. And one of the things that, is interesting is that I'm noticing that a lot of things now are focused on not just money, but patient safety. Strict protocols, avoiding substandard care. I mean, we've got the AI issue coming out,
Yep.
trying to avoid technical violations. So my question to you, or I guess, just throwing it back to you, where, when you're, engaged for your services, whether it be a provider or a clinic or, an organization says, hey, we're in trouble, or hopefully you get the ones that say, hey, we're not in trouble yet. Can you make sure we
Right.
stay out of trouble? I like the
That's right.
proactive people. Do you have them put together like a checklist, to, make complex legal regulations simple with actionable steps like a compliance program or plan? Or how do you start that conversation, or at least start that process?
Yeah, and it's actually still amazing to me sometimes how frequently we'll be engaged and we'll start, and one of the first questions that you're asking are like, well, we'd like to review what your current compliance program looks like, right? Can you go ahead and send us your written compliance
I
plan?
know where you're going with this, and they don't
And
have one.
they go, what's that now, right?
Yeah, what do you mean? What is it that you're looking for? Yeah,
We
where would
take
we find
compliance very seriously. We
that?
have nothing in writing on the topic, but we care deeply about it, right?
Yeah. Do you know what
And
just on a side note, there's been payers now that say that have actually walked into practices. I've had 2 over the last 5 years and said, we need your compliance manual. They walk in and ask for it.
Yep.
I was like, what? And they said, yeah, they're here from one of the big, I won't mention who it is, one of the big four. And they asked us for a compliance, manual. They wanted the actual spiral bound notebook.
hmm I've seen that as well. I've
Wow.
seen that as well. Yeah, on a couple of occasions. And it actually makes sense, right? If you think about it, because um, it's sort of like the bare minimum that you can do in some absolute sense is to like actually have it.
Yep.
And I get it. Everything's paperless in 2026, but if you've got people that are actually consulting it from time to time, I think there's, in some ways, not an unfair assumption that, well, there probably should be a physical copy or two around there somewhere.
Yeah.
Um,
It's weird
so,
because I appreciate the government saying, again, putting together the, general compliance program guidance. But it seems like some of this voluntary, and I'm air quoting, framework, they're saying this is a yardstick for, healthcare entities to measure their commitment to compliance and avoid fraud, waste, and abuse. But like you said, you've said, okay, well, let's see where you're at. What do we have to work with or to start with? And Colin, I get the same thing. Even in the revenue cycle management or billing coding office, they're just like, well, we don't know where it is, or I don't think we have one, and they whisper it. It's pretty kind of
right,
weird.
right.
How do you
Well,
start there?
yeah, I mean, so it's, I think typically I think about it as trying to do two things simultaneously when we run into that kind of a situation. So on the one hand, we're obviously going to help that organization actually stand up a more formal compliance program in writing with the appropriate bells and whistles, and crucially actually sort of design it so that it reflects the realities of the particular part of the industry that they're in as well. Because I will say, just as a side note, I've seen people say, "Oh yeah, we absolutely have it. Here you go," and it's something that they've just printed off of the internet, right? And it like is for
I'm trying
not
not
at
to
all,
laugh.
not at all their practice, right? Basically, right? And
Yeah,
so
got it off
um,
Facebook. I know.
yeah, so we'll help them put one together, for a go forward. But then, I think where you're looking back historically, the question becomes, okay, if we don't have something that was in writing then, let's at least try and figure out and recreate what were some of the good things that you were doing, even though it wasn't called a compliance plan, right? And so, from a billing and coding perspective, for example, I will often find out that organizations may actually have been doing rather good things to try and ensure sort of compliance that they didn't dress up as a compliance program, but that are like really helpful if I like need to go talk to the government or a regulator about something, right?
Right.
And then there can be other similar things. It's like, well, we don't have in our compliance program that we're going to do exclusion screening for employees, but like, oh, well, we always make sure that we screen for exclusion purposes, right? Oh, okay, you do? Great. There's a checklist about that.
Yeah.
Cool. And oh, like, so you do like internal like billing and coding audits to make sure that people are hitting X, Y, and Z sort of aspects of whatever your particular practice is. All right, well, that it turns out that's helpful, right? So trying to like ask the right questions sometimes is like pulling teeth, but sort of piece by piece extracting like what the positive things are that are out there.
Yeah, and sometimes when I get I don't know what you're talking about when I say, where's your compliance manual or compliance plan, who knows what they call it, policies, anything. I'm like,
Right,
okay, let's start again. Do you have an employee handbook? And
right,
they're
right,
like,
right.
we did years ago. And then I'll say, okay, how about physician contracts? Let's start there. And usually I can get somewhere there. They're
Yep,
like, oh, okay. I'm like, yeah. What does the physician have to do to get paid? What is their contract to be here? And let's see if you have benchmarks, or physicians are competitive, so they like
yep,
comparative data. They want to see peer data. Do you make sure that internal audits are done on them? It doesn't have to always be punitive, but some internal audits and share results to show areas where certain things are slipping. Fostering a culture of improvement. Sometimes punitive, audits are the most effective, but you want to start somewhere. But in talking about just the back and forth on, well, where does it say that I feel like I need to have a bumper sticker. um, I try to, and tell me if this is something you do, I try to emphasize operational efficiency over law. What is the best practice and the tools to reduce your administrative burden and be successful, such as like real-time documentation rather than late entry when you're charting,
Right.
saying that this is going to reduce a headache of hours of documentation later, and also will hopefully solve any kind of, invited legal risk and auditing risk. Automation, using your technology to your advantage and not to your detriment, and, with workflows and things like that. So I try to take that, step. But from a legal perspective, does that always work for you? Because I know once a practice of provider, whoever comes to an attorney, they're usually looking for black and white. And, where does it say that I can or can't do that?
Yeah, I think that your approach still is a big part of what we do as well. And for me, um, making sure that we don't always just talk in legalese or exclusively through reference to statutes or case law that says you can or can't do something. Um, my clients tend to actually appreciate me as an attorney in our firm because we're actually invested in understanding their business. And um, I'm at a boutique law firm. I'm a partner at a boutique law firm. I am, in a real sense, a small business owner myself, right? And so I try and approach people from that kind of shared experience in some ways, because if you're in a conversation about problem solving and you can identify um, business positives in and around changes that, for one reason or another, I sort of feel like are necessary. I think clients feel more heard and understood in that context, and I think they're actually many times more likely to be open to, the process changes or whatever it is that we're proposing. Now, sometimes the answer really is, and in addition to this being good for your business, you just can't do that because here's the legal risk that attaches. And so, we share that as well. But I get much better results, Terry, when I'm having a conversation that feels more like I'm supportive of the business and trying to get to a way that things work for the owners versus just being the guy who says, you can't do that, you can't do this, you can't do that.
I'm the same way because, I try to have conversations with the providers that basically, especially if I'm going over an audit they failed.
Hmm.
And I don't just come at them and said, you know what, you guys are terrible. No, no, no. That's not going to get any kind of receptive, response. I say, well, okay, so let's start with what's good. So your documentation, you're hitting some elements that are good, that, are lay terms that is going to be helpful to a payer when they see it. Now, I'm thinking and this always is a good response, I'm thinking you're seeing pretty complex patients. I'm just not seeing it in the documentation. And I want you to
Right.
get paid for what you're doing. I say, so
Hmm.
here's what I'm seeing, and then this is what equals, that code or whatever. So if you're seeing your down code, it's because I'm just not seeing it. And they're like, oh, you're right, this and that. And I said, you're a cardiologist or you're a rheumatologist. Just because it's an unspecified pain, the workup you have to do in your specialty, you need to tell me, what other medications the patient's on, what impact does that have on what you'd order for them, things like that. And they don't always realize that, yes, less is more from a padding the, the drop down screens and the check boxes, but I want to see specific patient information,
Right.
and that makes a difference. So, I think that, you're right. You have to give the positives with, the negatives. They're gonna, I mean, obviously they don't search us out, unfortunately, if there's not something they want to know they could do better.
Sure.
But it definitely has to come with being involved in wanting them to have a successful overall business, not just this, you know, um, small amount area or carved out compartmental area of their business.
Yeah, and yeah, I think this is a related but somewhat distinct point. Um, you don't. I never want to be in a position where I'm just reading off a list of problems or things that somebody isn't doing well, where we
Right, me
haven't given
either.
some thought. Yes, absolutely, to also flag the things that are going well, but come prepared with some proposed solutions to the problems as well, right? Here is a system change that you can make that will correct or avoid sort of this problem coming up in the future. And to the extent I can, try and propose systems that may also actually make them more profitable, right? Which is often possible. No, not all the time.
No, not all the time, but that's my goal as well. It's funny you say that because I don't know if you watch any streaming shows, but I like watching some of the old stuff like West Wing or Suits or Madam, what is it, Madam Secretary? There's some things now. I do like the premise and the writing because some of the things, just what we were talking about, where some of the staff members or the legal people that aren't attorneys would come in and they'd basically say, so here's, the problem I found it. And they just get looked at by the attorneys or by the administration and they're like, and what is your solution? And they don't have anything. And so I do the same with that you were saying. At least I try to come in with, now here's how I would respond to this, or here's a couple suggestions. I need some feedback to see how we can implement this.
Exactly. And I find that really, it creates a real sense of credibility with clients. And for me, that's important because, not infrequently, there will be other aspects of the representation where, I sometimes do have to deliver really difficult advice. Sometimes the answer is there's a very serious problem here that we need to do our best to sort of resolve. It can range all the way up to, in theory, individual liability on the criminal side of things, or very serious ramifications for individual companies. And so, it's really helpful for me with those clients who can understand, my default response to everything isn't just, don't do this anymore, you can't do this anymore, and I have no way or no offered sort of advice that would actually allow you to move forward. The really difficult feedback is easier to take where they know that I'm genuinely trying to look for paths forward and to be practical.
I love that. Well, I think this has been a great topic, and I really appreciate Colin for being our guest today on the podcast. Thank you so much for being here.
Absolutely. Thanks for having me.
To find and contact Colin for healthcare-related legal needs, you can go to the NSCHBC website at nschbc.org and click on Find a Consultant. Type in his first name, Colin, Colin, or his last name in those fields, and his information will appear. Also, as a reminder, the nschbc.org website offers monthly free webinars on a variety of topics, as well as a quarterly Medicare regulatory update, which actually I present as well. Please go to nschbc.org and click on the tab Upcoming Education. We have a variety of topics for 2026 that you don't want to miss. That's it for us today, everyone. Make it a great day, a great month, and thank you for listening to the award-winning NSCHBC Edge Podcast. I'm your host, Terry Fletcher.
Thank you for listening to the NSCHBC Edge Podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.